Dr. R Panchamukhi, consultant physician and practicing diabetologist, Harvard. Today, I am speaking on an interesting topic of treatment of hypertension in CKD patients, especially diabetic CKD. Because majority of the chronic diabetic patients, they land with kidney failure and they need very strict control of blood pressure. Their blood pressure will be varying day by day. Hence, control of blood pressure is an important aspect in treating diabetic CKD. Of course, any CKD. Majority of the patients, diabetic, 25 to 30% of diabetes, they end up with chronic kidney disease, especially after 15 to 20 years of their diabetic grade. So diabetic kidney disease is diagnosed by means of proteinuria, that is more than 300 mg per day, and decreased glomerular filtration rate, GFR. According to the level of GFR, they are classified from grade 1 to grade 5 or stage 1 to stage 5, where GFR more than 80 is supposed to be normal. Usually it is 80 to 120. So less than 80, less than 60, less than 40, less than 35, and less than 18, something like that, the stage CKD. Stage 1, stage 2, stage 3, stage 4, stage 5. Stage 5 CKD is when GFR is less than 18, or some people say it is less than 15 ml per minute per square meter body surface area. That is also known as ERD, end stage renal disease. So the treatment of this diabetic CKD has many aspects. First and foremost is control of blood pressure, very rigid control of blood pressure. Second one is control of diabetes mellitus. Then avoiding smoking. Fourth aspect is strict diet pattern, especially reduced protein intake. And fifth one is avoiding smoking and alcohol. So these are the 5 cornerstones of treating diabetic CKD. And nowadays, even regular walking has also been added by the European Society of the Diabetic Kidney Disease Control. They also add regular walking is also an important aspect of controlling this CKD effect. Now coming to the control of blood pressure, which plays a vital role in prolonging and preventing these CKD patients landing in dialysis or kidney transplantation. Along with control of diabetes, control of blood pressure is essential part in these individuals. Usually CKD patients, they present with very high blood pressure, not controlled by 1 or 2 drugs. At that time, we may have to use multiple drugs. One drug that has given a lot of scope and lot of encouragement in this group of disease is combination of telmisartan and cilnidipine. Telmisartan belongs to ARB category and cilnidipine belongs to calcium channel blocker. ARBs and ACE inhibitors, they are the main line of treatment for controlling blood pressure in diabetics, especially so in diabetic CKD. Because telmisartan has its effect on afferent and efferent glomerular arterioles, where thereby they reduce the efferent arterial pressure and thereby increase the glomerular secretion. Because of RAS inhibition, they have their own role. Telmisartan has own role in controlling the blood pressure, especially in diabetics. Increased dose of telmisartan also plays a role in decreasing proteinuria and thereby prolonging the course of CKD. Usually, we use 80 to 120 milligrams of telmisartan in these individuals, usually in divided doses. 80 milligrams BD or 80 milligrams morning and 40 milligrams at night. So because of RAS inhibition, they play an important role in controlling blood pressure in these individuals. And also they play an important role in preventing sympathetic overactivity of the renal vessels, and thereby they decrease protein excretion. So proteinuria is very well controlled with ACE inhibitors, especially with telmisartan. So telmisartan plays an important role in controlling blood pressure. Whenever single drug is not efficient in controlling blood pressure, then we add another drug. And here we are adding calcium channel blocker, that is cilnidipine, which is very effective because of its effect on L and N receptors in controlling the blood pressure and also reducing the protein excretion. Cilnidipine has very less side effects compared to other class of its drugs like amlodipine, which has tachycardia and pedal edema, and diltiazem and verapamil, which have bradycardia. Cilnidipine, it doesn't have sympathetic activity, hence it controls the patient. It has very less effect on heart rate, so there is no reflex tachycardia in these individuals, and also hardly we have seen pedal edema, and it is neutral action on cardiac conductivity. So because of its safe effect on CVS effects, it is preferred drug. And whenever you use combination of telmisartan plus cilnidipine in required dose, the side effects of other drug is nullified, and we achieve a synergistic effect in controlling the blood pressure effectively and thereby reducing the proteinuria and thereby improving GFR, and also the morbidity and mortality in these patients is very much diminished. So the combination of telmisartan and cilnidipine is very ideal drug therapy for controlling hypertension in CKD patients. And we are unable to control blood pressure with this combination, then we add diuretic, especially loop diuretics. The only side effect of ARBs in these individuals, especially in elderly individuals, is hyperkalemia, which we should be looking for. And regularly we should test serum potassium level in these individuals. Except that one, we have absolutely no side effect of this combination. So every 10 milligram mm of mercury of systolic blood pressure reduction in these individuals will reduce the mortality by 15 to 20%. And also ongoing dialysis period is also reduced. So control of blood pressure by this combination plays an important role in these CKD patients. And then we have control of blood sugar by reducing HbA1c. So 1% of HbA1c reduction in these individuals reduce mortality by 25 to 30%, severe mortality. So controlling blood pressure, we can prevent many hazardous effects in these diabetic CKD patients because they are more prone for heart attacks, more prone for left ventricular failure, cardiac failure, they are more prone for strokes, and even they are more prone for strokes, either infarctive strokes or hemorrhagic strokes, and they may land up in end-stage renal failure if their blood pressure is not controlled. Ideal blood pressure for these individuals nowadays is 120 by 80 millimeter of mercury. If the kidneys are not involved, the accepted blood pressure control is somewhere between 130 to 140 by 80 millimeter of mercury. But once, if there is proteinuria, or what you call it as the patient going for CKD, then very strict rigid control blood pressure, say somewhere 110 to 120 systolic and 80 to 84 diastolic is important. And even some people advise ambulatory blood pressure monitoring in these individuals so that we can have 24 hours control of blood pressure. So blood pressure control by using the combination of telmisartan and cilindapine in proper dose plays an important role in controlling this diabetic CKD prognosis, and we can prevent many patients going into either dialysis or transplantation. In our practice, we have seen control of strict blood pressure plays an important role, and also they are asked to take less amount of salt. Salt restriction, protein restriction, optimal blood pressure control, good control of diabetes, avoiding smoking and alcohol, control of cholesterol level, regular walking, they play an important role in controlling the blood pressure in these individuals. Nowadays, we are adding even nebivolol, some dose 5 mg or 10 mg to prevent sympathetic overactivity in these individuals, along with telmisartan and cilindapine, so that optimum blood pressure control is achieved